Hello, my name is Victoria Starnes, and I am a current second-year medical student at the University of Toledo College of Medicine and Life Sciences. I am presenting a case put together by myself, Dr. Kelly Lutman, current third-year medical student Kylie Rostad, and current third-year medical student Catherine Gerthart, and Dr. Joan Duggan. This case is Mycobacterium kansasii presenting as a pleural effusion. Mycobacterium kansasii is a nontuberculous mycobacterium that is slow-growing and atypical acid-fast. It was previously thought to be a contaminant or colonization when it was grown in culture. However, now it's recognized as a cause of many human diseases, similar to that of Mycobacterium tuberculosis. Pleural effusions are very rarely seen with Mycobacterium kansasii, which is why this case was of particular interest to us. This case is a 56-year-old female who presented to the emergency department complaining of shortness of breath and pain in her left chest. At this time, she didn't have any other symptoms. However, 3 months prior, she had presented with the complaint of hemoptysis. At this time, 3 months prior, workup revealed abnormal pulmonary function tests, and a CT scan of her chest was suggestive of atypical mycobacterial or fungal infection. This CT scan can be seen to the right, with CT March 2020 showing multifocal nodular opacities in a tree and bud distribution on the left side. A sputum sample grew Mycobacterium kansasii, and follow-up bronchoscopy was positive for acid-fast bacilli. At this time, she was started on azithromycin, ethambutol, and rifampin. 3 months later, at the time of presentation in the emergency department, the patient reported that she had not yet started ethambutol or azithromycin. At this time, chest x-ray showed a new loculated left pleural effusion at the left lung base, with tracking along the left lateral pleural surface. A left-sided chest tube was placed, and 1.5 liters of fluid was drained in the first 24 hours. This fluid had lymphocytic predominance and was acid-fast bacilli positive, although cultures have continued to remain negative. A CT scan at this time in May 2020 showed pleural effusion at the left lung base. Ultimately, she was discharged with instructions to resume her original medications of azithromycin, ethambutol, and rifampin. She has been taking these medications as prescribed since discharge, and her condition continues to improve. Most frequently, bronchopulmonary disease is the presentation of infection with Mycobacterium kansasii, commonly presenting with symptoms of fever, night sweats, weight loss, cough, and hemoptysis. Pleural effusions are really rarely seen with this bacterium. When they do present, however, they are typically associated with immunocompromised states, specifically positive HIV status, organ transplantation, and hematologic malignancies. The major takeaway from this case is that pulmonary infections due to Mycobacterium kansasii can be clinically indistinguishable from those due to Mycobacterium tuberculosis. This is an important distinction to make in clinical workup, as the treatment regimen for Mycobacterium tuberculosis is not effective against Mycobacterium kansasii. While Mycobacterium is more closely associated with the finding of pleural effusion, and it might be the first thing to jump to, it's really important to keep a broad differential, especially in immunocompromised patient populations. And that concludes this case presentation of Mycobacterium kansasii presenting as a pleural effusion. Thank you to everyone who has taken the time to work on this project or has taken the time to listen to it. Please feel free to contact me at the contact information in the bottom left-hand corner.